My topic is, can we predict the outcome of anti-VEGF therapy in ARMD cases? I'm Dr. Shakib from RAHS Islamabad. And the other questions are, do all ARMD patients get benefit from anti-VEGF intravitreal injections? And can we predict the outcome in real world? There's difference between controlled studies and real world. Actually, in controlled studies, we have patients who are already booked, they are on register, and they are being provided medicines in time. So that's not a real world setting, that's an ideal setting. And then we can see the effects of the drugs. But in real world, when the patients are not very compliant, they come on their own, they have financial issues. So we can't administer intravitreal injections in time and not in full doses, not in full regime. So the outcome in real world is totally different from what we get in the otherwise controlled trial studies. So the answer is yes. We can do it through clinical course of the disease. If we see it critically, we can predict well in time that this gentleman or lady is not going to have a lot of benefit from the injections, or he or she can. And by critically analyzing the OCT at the start, the first OCT that we see in a patient, we can tell that what we are going to do. Why should we do it? Because we have to make a decision whether we are going to give intravitreal injection or not, and how much. And we have to counsel the patient. Of course, we have to give the treatment, but then we counsel accordingly that this much benefit are you going to get, this much investment you will have to do, so many months you will have to come for injections. So he or she can plan it well before time. Clinically seeing a patient, this is a patient with drusens, confluent type, straight, hard type, and different type of, so one can make a little clinical sense that in which direction the disease is going to move. But it's the study, there was a trial, there was a study of comparison of different ARMD trials, and what they did was that they so this is real world study, and then they selected some patients, and then they divided the time into 5 patches. The first group was the patients who were treatment naive. They were not given any injection before. And the other group of patients were the pre-visit, in which the last intravitreal injection was given before visual loss. Some clinicians saw it. The patient was having a good vision, 6/6 or 6/9, and at that time the injection was given, right in the start of the disease. The other group was baseline visit. Baseline visit, intravitreal drug during visual loss. A patient एक आता है कहते जी मेरी नज़र तो खराब हो गई है, उस वक्त जो आप वो उसको हम baseline visit consider करेंगे. और then it was studied on month 3 and then month 6 and then up to 9th month. So what they did, that they divided into 2 patches, that patients who were treatment naive, from here till baseline visit, how much time did they take to develop from this to this. So they saw that if you start the treatment early in treatment naive patients who have not yet suffered from the problem, they take about 36 weeks to start having a little problem in the vision. Right? So it may be less. So all the patients do have deterioration of vision. It's not that you can totally stop them. But the patient who come early and they are treatment naive and they get good treatment, right treatment, they take a longer time. But the patients who start a little late, they take about 9 weeks to come to this stage. So the patient who come late and they have already got treatments from 1 to other doctors or different type of treatments or different regime, now when they start getting the treatment properly, they take less time to get their vision worse. And then these were also studied in the later months also. So what happened was that about 6% of the patients overall, they had a sustained loss of vision. 6% लोगों ने sustained slow loss of vision किया ही किया. 1 out of 4 patient had an abrupt loss of vision. Abrupt loss of vision is defined as 15, greater than 15 or equal to 15 EDTRS letters loss of vision at any point of treatment. But 59% of patients had no recovery after 4 weeks of intravitreal injection. कुछ लोग ऐसे थे जो लेट है और we have seen it कि कोई फायदा नहीं होता. कई दफ़ा पहला टीका लगाया तो कोई पता नहीं चलता, 1 महीने बाद वैसे के वैसे होता है पेशेंट. So most of them were like this in real world. I'm talking of real world. But some patient also had random or sporadic loss of vision, that is again 15 or more letters followed by 10 letters recovery. This is also seen during के वो 15 लेटर या काफ़ी बुरा उसका हाल होता है, बट 4 वीक्स के बाद वो काफ़ी बेहतर सा हो जाता है. पूरा बेहतर नहीं होता, बहुत अच्छा होता है. So all these categories do have a slow loss of vision, but these categories who have abrupt loss और रैंडम लॉस जो थोड़ा रिकवर भी कर जाते हैं, इनकी प्रोग्नोसिस अच्छी नहीं है. ये हमारा क्लिनिकल सेंस बताता है. सो इट वाज फाउंड दैट इट वाज नॉट अनयूजुअल इन रियल वर्ल्ड to get this much loss of letters occur between 2 consecutive intravitreal injection, often within 9 months of diagnosis and 2 months after the last intravitreal dose. So dose follow-up and proactive regimen should be preferred at least in the first year. So if the patients are naive or early treatment, and in first year, if they follow proper regime and they get timely injections in full dose, then they have good prognosis. अगर उसमें कहीं वो आपने हिस्ट्री ली, पता चला जी मैं 2 वहाँ से लगाए हैं टीके, फिर मैंने 6 महीने नहीं लगाए, उसके बाद मैं अच्छा हो गया, उसके बाद एक और किसी डॉक्टर साहब ने लगाया, मैं ठीक हो गया, फिर अब 6 महीने गुजर गए, अब मैं दोबारा खराब हो गया हूँ. तो दिस काइंड ऑफ हिस्ट्री हैज अ बैड प्रोग्नोसिस, राइट. सो another, now we move on to the OCT, and in OCT the thing which is talked of is this SHREM, we call it subretinal hyperreflective material. What is it? Subretinal hyperreflective material is a morphological feature seen on optical coherence tomogram as hyperreflective material located external to retina and internal to the retinal pigment epithelium. ये मैंने सिंपल सी इसलिए बनाई है ताकि एकदम आपको पता चल जाए कि ये कहाँ पड़े होते हैं. ये It's in the junctional zone. Ellipsoid zone से भी नीचे होते हैं. Junctional zone where rods and cones they intermingle with the villi of the retinal pigment epithelium, वहाँ पे ये पड़ा होता है. So this is just a simple diagram to show that we are talking about this zone. This is retinal pigment epithelium. This is outer segment of rod and cone. This is ellipsoid zone, which is the cilium, और इसको bacillary zone भी कहते हैं. And this is internal outer nuclear the inner segment of the rods and cones, and this is external limiting membrane, and this is the outer nuclear. ये न्यूक्लिया हैं rods and cones की, इतनी बड़ी जो लेयर है, यहाँ तक फोविया तक यही हैं सारे. So here is the longest rods and cones you find here. We are concerned about this place. This is ellipsoid zone, red. This is RP, and we are concerned about this zone, right? So this is again, I like black and white mostly. OCT जब मैं रीड करता हूँ मुझे black and white ज़्यादा अच्छा लगता है, because इसमें ज़्यादा well defined चीज़ें आपको मिलती हैं. This is the place we want to see, right? So SHREM can be subclassified as hyperreflective, और इसको हम compare कर सकते हैं on ground, same reflectivity as RP. If there is a material abnormally placed and its reflectivity on black and white on the gray tone of the OCT is that of RP, then we call it hyperreflective. And if isoreflective, it has got the same reflectivity as plexiform layers. ये उससे थोड़ी सी कम dense होती है. And hyporeflective is same as nuclear retinal layers, ये बहुत कम dense होती है. तो on ground उसी OCT पे we can define, categorize कि ये hyper है या hypo है या iso है. और उसी पे उसकी प्रोग्नोसिस आप पहले ही ओसीटी में ही आप तय कर सकते हैं कि इसकी प्रोग्नोसिस पेशेंट की क्या होगी। इफ श्रैम इज हेट्रोजेनियस, और अगर हेट्रोजेनियस है, हर तरह का वहां पड़ा हुआ है, देन वी लेबल इट अकॉर्डिंग टू द हाईएस्ट रिफ्लेक्टिविटी पॉइंट इवन इफ प्रेजेंट इन डिफरेंट एरियाज। तो फिर अगर एक जगह भी हाइपर रिफ्लेक्टिव है तो हम उसको जो हाईएस्ट होगा उस पर उसको लेबल कर देंगे और वहीं से उसकी प्रोग्नोसिस तय होगी। पैथोलॉजीज विच आर सीन इन दीज एरियाज आर सबरेटिनल फ्लूइड, इंट्रारेटिनल फ्लूइड, हाइपर रिफ्लेक्टिव फोसाई and disruption of external limiting membrane, ellipsoid zone and interdigitation zone। ये सारी पैथोलॉजीज हमें इन एरियाज में जहाँ पे मटेरियल पड़ा होता है हमें मिलती हैं। अ लिटल रिवीजन और थोड़ा सा इसको देख लेते हैं। दिस इज हाइपर रिफ्लेक्टिव। अब हाइपर रिफ्लेक्टिव ये है जो पड़ा हुआ है और ये न्यूक्लियर लेयर के साथ कंपेयर हो सकता है। दिस इज आइसो रिफ्लेक्टिव, ये जो पड़ा हुआ है, और ये कंपेयर हो सकता है प्लेक्सीफॉर्म लेयर के साथ, ये मैंने इसलिए बताया आपको। और ये हाइपर रिफ्लेक्टिव है और ये कंपेयर होता है रेटिनल पिगमेंट। रेटिनल पिगमेंट एपिथेलियम ये जा रही है, देखें ये है, ये उसके ऊपर पड़ा हुआ है मटेरियल ये सारा, और इसकी रिफ्लेक्टिविटी या डेंसिटी इज कंपेरेबल टू दिस। सो दिस इज हाउ वी लेबल। और मजे की बात यह है कि ये जो हाइपो और हाइपर है, हाइपो और आइसो जो है, बेसिकली देयर फाइब्रिन एंड हेमरेजेस। और अनडिफाइंड मार्जिन अगर होंगे तो वो फाइब्रिन होगा, और डिफाइंड मार्जिन होंगे तो वो हेमरेज होगा। इनकी बहुत अच्छी रिस्पॉन्स टू ट्रीटमेंट है। सो आइसो और हाइपो अगर आपको पहली ओसीटी में मिला है तो आपको पता है कि आपकी इन्वेस्टमेंट बेहतर है, आप पेशेंट से कह सकते हैं इंशाल्लाह बेहतरी होगी, आप इसको प्रॉपर ट्रीटमेंट कराएं। एंड इफ यू हैव दिस काइंड ऑफ थिंग तो इसमें न्यूरोवेस्कुलर और फाइब्रोटिक एलिमेंट ज़्यादा होता है और इसकी बैड प्रोग्नोसिस। तो आप पहले दिन हिस्ट्री से भी और ओसीटी से भी आपको पहले पता चल सकता है कि मैं क्या करने जा रहा हूं पेशेंट के साथ। दिस इज अ रियल वर्ड, एक आपको बता देता हूं, और इसका ये इट्स अ काइंड ऑफ आइसो रिफ्लेक्टिव अगर आप देखें, और ये ओवर द पैसेज ऑफ टाइम रिड्यूस होता होता खत्म हो गया है। ये हाइपर रिफ्लेक्टिव है, देखें ये दिस इज हाइपर रिफ्लेक्टिव फोकस और फोसाई, और यहां पे एक फाइब्रोटिक एलिमेंट अगर आप देखें ये नहीं जाएंगे। अब ये आपको पहले ही पता है, पहले दिन पता है, सॉरी ये आपको पहले दिन पता है, देखें ये नहीं जा रहे, पानी निकल गया, ऐसा रफ निकल गया, लेकिन ये एरिया नहीं खत्म हुआ। सो यू कैन टेल, अगर ये आपको बीच में नजर आ गया फाइब्रोसिस हाइपर रिफ्लेक्टिव फोसा है, तो ये इसकी प्रोग्नोसिस आप देख लें 9 मंथ्स के बाद या साल के बाद क्या, और इसकी प्रोग्नोसिस देख लें, पहले दिन आपको पता चल जाता है व्हाट आई एम गोइंग टू डू। सो ओवर अ पीरियड ऑफ टाइम इफ यू सी, तो हमें पता चल जाता है कि एसएचआरएम जो हाइपर ग्रुप है उसके अंदर आपकी परसेंटेज ऑफ रिजॉर्प्शन ऑफ बेस लाइन प्रेजेंस ऑफ एट द बेस लाइन क्या था आपका एसआरएफ, और 12 मंथ्स के बाद क्या हुआ, तो इट वाज नॉट मच ऑफ अ डिफरेंस, जबकि हाइपो में वो 0 हो गया। सब रेटिनल फ्लूइड देख लें आप, इसमें उतने का उतना ही तकरीबन रहा है, और यहाँ देखें आप कितना कम हो गया हाइपो ग्रुप में। प्रेजेंस ऑफ हाइपर रिफ्लेक्टिव फोसा 6% थे या 2 हो गए, यहाँ भी तकरीबन उतने ही रहे, क्योंकि ये ऑलरेडी हार्ड होते हैं, ये नहीं ख़त्म होते। एक्सटर्नल लिमिटिंग में डिस्ट्रप्शन जो हुई थी वो यहाँ पे देख लें 10 से उल्टी 11 हो गई, हाइपो में जो है वो रिड्यूस हो गई है, बेहतर हो गई है डिस्ट्रप्शन। एलिप्सॉइड जोन का जो डैमेज था वो ये देखें हाइपर रिफ्लेक्टिव में 13% ही रहा, 14 से 13 हो गया ज़्यादा, लेकिन हाइपो में देखें 3 पे चला गया, पहले भी कम था। विजुअल आउटकम अगर आप देख लें तो हाइपर ग्रुप में ये और ख़राब हो गई है नज़र, जबकि हाइपर रिफ्लेक्टिव में नज़र उसकी बेहतर हो गई है। तो ये 2 सिंपल स्टडी थी, जिसमें 2 मैंने एक तो, और वो जो स्टडी थी दिस वाज लेटेस्ट स्टडी, इट वाज इन जुलाई, प्रिंटेड इन जुलाई 2023, डन इन इटली। तो वो in real world में if you get a OCT and you take the history on the first day, you can tell the patient कि आपका it's just a quick revision। अगर यहाँ पे ट्रेनिज होते तो उनके लिए मैंने कहा था एक ऐसे कि बताएं ये क्या चीज़, इंटरनल लिमिटिंग मेम्ब्रेन होगी, ये गैंग्लियन लेयर हो गया, आउटर प्लेक्सीफॉर्म हो गया, सॉरी इनर प्लेक्सीफॉर्म, इनर न्यूक्लियर, इनर प्लेक्सीफॉर्म, आउटर न्यूक्लियर, ये एक्सटर्नल लिमिटिंग मेम्ब्रेन है, और ये मेम्ब्रेन है इनर सेगमेंट्स की, और इसके साथ ये अब जो एरो लगा है ये एलिप्सॉइड जोन है, ये ख़राब हुई हुई है ना जगह, सारी डिस्ट्रप्शन हुई हुई है, और ये जंक्शनल जोन आ गया आपका, जहाँ जिसकी हम बात करते हैं, और ये रेटिनल पिगमेंट एपिथेलियम है। अब ये एरिया देखें, इसको हम क्या कहेंगे, आइसो कहेंगे, हाइपर कहेंगे? हाँ, हाइपर और आइसो के दरमियान है ज़रा ये एरिया, ये हाइपो है, और ये एक्चुअली फोसाए हैं जो हाइपर रिफ्लेक्टिव है, और ये हाइपर रिफ्लेक्टिव एरिया बनता है। सो इसमें सारा, इसको हम लेबल क्या करेंगे फिर? हाइपर ही लेबल करेंगे, और इस केस की प्रोग्नोसिस आपको पहले पता है बहुत अच्छी नहीं है। सो patient who do the best with the treatment are the treatment naive patient and those presenting early, who avoid longer interval between two injections, who maintain healthy diet. वेरी इंपॉर्टेंट, ये कल इस पर जिक्र होता रहा था, तारिक साहब ने इस पर बहुत जिक्र किया था। हेल्दी डाइट एंड हेल्दी लाइफ स्टाइल बहुत इंपॉर्टेंट है इन चीज़ों के लिए, डायबिटीज़ के लिए भी। और एंड देन हु मेंटेन अ गुड कंट्रोल ओवर डायबिटीज, मेलाइटस एंड बीपी. So patients who are not benefited much with the treatment are the ones who have more fibrotic element in the lesion. ये OCT पे अब आप आ जाए. First year and usually continues to increase. Exudative fluid ज़्यादा हो. Degenerative intraretinal fluid और SRF यानी कि जिसमें structural changes आ गई और रेटिना में आप देखें वो degenerative fluid होता है. Different treatment regimes और bad compliance, इधर उधर से टीके लगवा रहा है, कभी कहाँ से लगवा रहा है, कभी more than 8 weeks interval in the first year of treatment. अगर पहले साल उसने 2 महीने से ज़्यादा गैप देने शुरू हो गए, प्रोग्नोसिस अच्छी नहीं. एंड स्पोरेडिक एब्रप्ट लेटरल लॉस जो मैंने कहा था between 2 consecutive visits अगर हो रहा है उसका, these cases have worse mean visual acuity after 2 years. So take home a very close watch at the course of the disease during follow-up, and critical analysis of OCT can help one make a decision for a rational treatment and patient counseling accordingly. Thank you.
Thank you, sir. Now it's my time, my presentation. CSCR as I saw. Bismillahirrahmanirrahim. We all know the definition and the risk factors and the pathogenesis all of about CSCR. So, but we would like to discuss that what I have seen in my cases and what I have done in my cases, and still we are on that we should go forward so that we can save the individuals who are in, you can say, working age group, because it affects the young individuals, and they are in the working age group, and they are affected with severe central loss of the vision, and they are with decreased vision for 3, 4, or 5 months. Now, this all has been done. Now, CSCR has been roughly categorized in acute and chronic. Acute CSCR usually resolves spontaneously. But how much time it will take to resolve spontaneously, this is the question. They say that within 6 months it can resolve. Some say that 4 months it can resolve. Then can you imagine that during these 4 months, this working age population who has been affected with CSCR, how they will work and perform their regular duties? Even one eye is affected and a stress factor is already there, how they will work. Sometimes there is bilateral CSCR, how they will work. Chronic can lead to irreversible deterioration in visual acuity, contrast, vision, and quality of life. Now these are the presentations. We all know how it is presented and investigations. Now coming to the treatment, there is still no specific treatment. But there are some studies, and on the basis of those studies we have worked. And number one is only you have to observe. Observation, discontinuation of the steroids if the patient is already on steroids, because the corticosteroids, they deteriorate the situation. Reduction and the avoidance of the stress is a very important factor. But some many studies are there. They have worked on the use of acetazolamide in these cases and eplerenone in these cases, spironolactone, NSAIDs, systemic beta blockers, topical carbonic and hydrase inhibitors. Now, what I have done, I have worked on CSCR for so many years. When I read the paper in ophthalmology, the Journal of American Academy of Ophthalmology, the role of acetazolamide in CSCR. And now I have also worked on eplerenone, the role of eplerenone on CSCR. Now, acetazolamide enhance subretinal fluid absorption and increase in retinal adhesiveness by causing acidification of the subretinal space. It inhibits gamma-glutamyl transpeptidase activity in ocular tissues and facilitates cellular adhesion, neutrophil chemotaxis, and degradation through elevation of leukotriene D4 concentration. And this I have taken from Ophthalmology, one of the journals of 2002 series. And the study I started in those 2003 and 4, and number of the patients were 53. Male preponderance was there. Number of eyes were 54 because some of the cases were bilateral. And age ranged from 19 to 52 years. Average age was 33 years. Unilateral were 52, and one case was bilateral. Now we divided the treatment, the cases into treatment group and in which the treatment was given, and another control group in which the treatment was not given, placebo treatment was given. Now, you see in the treatment group, the visual acuity improved. Now, before treatment, the visual acuity in 6 patients, in 6 eyes, was 6/60. But after treatment, there was no 6/60. It was reduced. Less than 6/60, then 6/60, then 6/36. But you can see that after treatment, the vision started improving. We saw 6/6 in 27 eyes. And then 6/9 in 9 eyes, 6/12 in 3 eyes, and 6/18 in 3 eyes, and 6/24 in 2 eyes. So there was considerable improvement in the visual acuity after the use of acetazolamide. Now, I am talking about during the acute phase. If we will wait for 4 to 6 months to just observe and wait for the spontaneous resolving of the improving of the visual acuity and resolution of this condition, what will these working age group people do? They will be disturbed and they are already under stress, and they will become, I think, they will go under the depression. So to prevent that, there should be rapidly resolution and improvement in the visual acuity. This study was conducted. Now this is one of the cases in which this is the before the use of the acetazolamide. You can see the subretinal fluid here, CSCR. And after the use of the acetazolamide, there is considerable improvement. And you can see here the visual acuity was 6/60, near vision was less than n18, and here the left eye 6/6, and near vision was n6. This is another case in which the acetazolamide was used before the treatment and after the treatment. Before the treatment, visual acuity 6/24, near vision less than n18, and after the treatment, before 6 months, within 2 to 3 months, the improvement was there. Now, What we saw in the treatment group, that there was duration of the subjective improvement and clinical resolution was 15 days to 1 month. Recurrence was seen in one case, one patient. Now coming to the eplerenone, then we heard and we read that the eplerenone has a good role in as a treatment of CSCR. How it works? It is a selective aldosterone receptor antagonist and potassium-sparing diuretic that was originally approved in 2002 by FDA for hypertension, treatment of hypertension, and was recently shown to improve visual acuity and significantly decrease central macular thickness in a small series of patients with chronic CSCR. Now, they have used in chronic CSCR, but they have labeled the chronic CSCR after 4 to 6 months. During the first 6 months, this is the acute phase, or that part of the CSCR in which there is development of the subretinal precipitates or other complications. Very little number of the cases, and we are still working on it. You can see before treatment in this patient and after treatment in this patient, but one thing is evident, that the subretinal fluid is still there, although the visual acuity has improved. It has become 6/6, but there is no fully absorption or resolution of the subretinal fluid. This is another case, and this is again improvement. Vision is improved, patient is satisfied, but when we perform OCT, we again see that there is the presence of the subretinal fluid. So this is a question mark that what to do. What is the conclusion? Number one, acetazolamide shortens the mean time of visual improvement and accelerate clinical resolution. And there is rapid resolution of the absorption of the subretinal fluid as compared to the eplerenone. Up till now, but we are still going on with the more cases with the treatment on eplerenone. Following eplerenone treatment of acute CSCR, accelerated, now this is in one of the research papers mentioned, the conclusion of one article which I have read, accelerated resolution in subretinal fluid occurred in comparison to placebo. Resolution in subretinal fluid, but in our study we have seen the still subretinal fluid is not absorbed and it is still present. So we are going on that how long it is true and how long it works. But there is a good difference in best corrected visual acuity. Eplerenone, they have mentioned that it is effective mode of treatment of CSCR, but we are still, our studies is going on and we will conclude it, and inshallah next conferences we will present. When there is chronic CSCR, now generally we should identify the risk factors because there are the risk factors. PDT remains the best option to CSCR, but where is PDT? Is PDT available in Pakistan? Where? I don't know. You might know. But when the lesion is subfoveal, when the problem is subfoveal. High density subthreshold micropulse retinal laser treatment with diode laser. They have recommended in chronic CSCR that you perform FFA, and if there is subretinal fluid leaking area, you can go for the laser if it is extrafoveal. Long-term follow-up studies are required to decide more safe and effective mode of treatment, prospective and retrospective. Thank you very much. Dr. Syed Abdullah Mazhar. His talk is on autologous platelets, rich plasma, a new innovation in the treatment of retinitis pigmentosa. Dr. Abdullah Mazhar.
Assalamu alaikum everyone. I'm Dr. Abdullah. I'm going to present autologous platelet-rich plasma for the treatment of retinitis pigmentosa. Probably a new innovation for us, but not in the other countries of the world. So we all know what is retinitis pigmentosa. It's a progressive photoreceptor degeneration, mainly rod cone. There are almost 260 genetic mutations which are identified in the photoreceptors and in the retinal pigment epithelium, which cause this disease. The main mechanism of retinitis pigmentosa is...
Button दबा दें, please.
So which button? Sir?
Red light जल रही? थोड़ा सा voice को थोड़ा सा
Okay. Sorry. Okay. So the main mechanism of disease is apoptosis and photoreceptor cell loss, which is the common in all types of retinitis pigmentosa. But the progression in different hereditary patterns is different. We all know. We all know about the symptom, that is night blindness, which after some time the day vision is also involved. There is progression of visual loss, there is constriction of visual field, which eventually leads to the total blindness. Central visual acuity is usually affected late because it starts from the periphery and it goes toward the center. And during this phenomena, the Muller cells, they get hypertrophied and they make some synapses with the other cells in the central 19 degree of the visual field. So the central visual field is safe until the late stages of the disease. So these Muller cells basically act by the paracrine effect, causing the remaining cones and rod cells to not to get involved or involved slowly and in the late stages. We all know about the signs, the typical triad of the RP, along with the complications, the cataract, epiretinal membrane, and macular edema. So I'll just skip to the pathogenesis. Is the main thing. The understood pathogenesis of retinitis pigmentosa is basically growth factors withdrawal or deficiency in the microenvironment, which causes the cells, the photoreceptor cells, and the RPE. There are two mechanisms by which this happens. First, they get into the apoptotic cycle and destroy themselves. And the second mechanism is they get into the dormant stage. Apoptosis of the cells causes reduction in the thickness of the outer nuclear layer and the RPE. Other genetic mutations which causes reduction in the production of the rhodopsin and growth factors which are required for the photoreceptors metabolism and the normal functioning. And this rhodopsin, lack of rhodopsin production causes opening of the calcium channels, which causes the death of the photoreceptors. So there is a time when this all is happening, like when the growth factors are, the amount of growth factors is decreased and the cells are still viable. In that time, the cells, the photoreceptor cells get into a dormant phase, that is called the dormant cycle or sleep mode or the standby cycle. So this is the stage where we have two cells population, one which are being in the dormant phase, the other cells which are being destroyed, which are undergoing apoptosis. So this dormant phase cycle, it differs in different types of the retinitis pigmentosa according to their genetic. The other mechanism proposed is that the glucose is not available for the photoreceptors because this gets sequestered in the RPE. So starvation leads to the decrease in the nutrients in the glucose content of the photoreceptors, which again lead to the mitochondrial destruction and destruction of the photoreceptor cells. So this genetic mutation also causes reduction in the capacity of photoreceptors to intake the nutrients and use them for themselves, and this also lead to the abnormality in the growth factor signals, which are required for the normal functioning. So these were all the proposed or the accepted mechanisms by the pathogenetic mechanism by which the cells are destroyed in the RP. So now we come to the autologous platelet-rich plasma. What is this? It's a biological product which has rich concentration of platelets, and in turn platelets have rich concentration of growth factors. So autologous platelet-rich plasma is a good source of growth factors. These are more than 30 growth factors and cytokines in the granules, and more than 800 different proteins which can act in the paracrine manner or in the surrounding cells for their nutrition and for their normal working. These are the mechanism, as we all know that alpha granules have so many growth factors. So these growth factors can cause cell proliferation, angiogenesis, and cell migration, which is required for tissue regeneration. The neurotrophic, anti-apoptotic, hemorrhagical, and immunomodulatory actions of growth factors and cytokines, which lead on the residual photoreceptor cells, which make them viable and make them to continue their proper functioning. Along with that, growth factors also causes the regulation of the energy cycle and local increase in local capillary blood flow, neurogenesis, and cellular metabolism. There is a hypothesis, or there is accepted theory that there is also some limit of inflammation in the retinitis pigmentosa also. There is also inflammation in retinitis pigmentosa. So these growth factors also have anti-inflammatory effects through the cytokines. All other these endothelial growth factors, fibroblast growth factors, platelet-derived and activating factors, these all factors are also present, which causes endothelial regeneration, angiogenesis, and hyperperfusion. So basically the main thing is what growth factors are doing, they are promoting the angiogenesis, perfusion, they are stabilizing the microenvironment of the cell, they are making cells more viable by providing them indirectly or indirectly with the nutrition, with the oxygen. So the trophic capacity of platelets having the platelets rich in growth factors, that is the effect. Trophic effect is like effect on the surrounding cells, which the nutritional effect basically, which promotes the growth of the remaining cells. So these neurotrophic factors, they act on the microenvironment, and they activate the photoreceptor cells which are in the sleep mode. So basically they are stopping these cells for in getting in the apoptotic cycle. So how we are going to inject this? We make the PRP from the patient's own blood. We activate it through either sodium chloride, sodium citrate, or calcium gluconate. And then we start with the 3 loading doses with 2 weeks of interval. And then there is a booster dose with every 4 to 6 months interval, because the half-life of growth factors is about 4 to 6 months. So it is said that the growth factors can decrease the photoreceptor cell loss rate by approximately 3-fold. So now how growth factors act? They actually reach the suprachoroidal space through the scleral poles, and also use the gateway through the tyrosine kinase receptors. The molecules which are smaller than 75 kilodaltons can pass through the scleral pole. So all these growth factors have the size around 10 to 30 kilodaltons. So these can easily pass through these pores. There are also other sources of growth factors other than patient's own blood, and that is fetal bovine serum, allogenic serum, or umbilical cord serum. But the limitation arises because these sources can have higher risks of allergic reactions and infectious disease transmission. So this is the main thing, how we are going to assess the result in the RP patient, because as we all know that usually these patients, when they come to us, they usually have a very severe loss of vision. So how are we going to assess? Visual acuity is the first thing, although not a very reliable way of assessing the result, but still a good one. Not reliable, I said, because the central vision is spared till the last of the disease. But if the central vision is not decreasing or probably improving, then we can say, yes, it's a reliable method. Visual fields, yes, it can be done, and there are changes in the visual field, but still there are subjective parameters which are involved, which causes visual field a less reliable method of assessing the result. Microperimetry, it's a more reliable because it assesses the central 10 degree. So we can say, yes, it's a more reliable assessing tool as compared to the 30-2 visual field degree. Furnace
Please,
autofluorescence.
Dr. Abdullah, if you conclude it.
Yes, sir.
Your
Yes,
time
sir.
is already.
Okay. So furnace autofluorescence, we can see there is hyperfluorescent rings which gets constricted. OCT, as sir already told about the ellipsoid zone, we see the width of the ellipsoid zone, and we compare it that with the serial OCTs, that in the progression of the disease, ellipsoid zone width is decreased. So this is, we can see in the upper picture, we can see that there is a ellipsoid zone width. In the lower one, the width is decreased. So this happens in the RP patient. ERG is there are two types of ERG: multifocal and full field. Multifocal ERGs gives us response at the different points of the retina. Full field gives us in the whole retina. So decrease in the amplitude and increase in elicit time. This happens in the RP patient, but it gets improved with the PRP therapy. This is the most reliable method for me because the patient, which he says, and patient reported that they get a good visual acuity after this injection. They have a improved perimetry. They can see things from the side, and they have colors seem brighter and clear. So this is the more reliable, although subjective, but probably the more reliable method. Safety outcome, it's just like as we usually inject Septinon. So we all know if there are any side effects, the same side effects as we inject the Septinon injection of other drugs. So otherwise, it's a totally safe procedure if we perform it carefully. Potential systemic side effects are usually allergic reaction, but they can be avoided if we use autologous serum. So conclusion is Septinon injection of PRP is a good therapeutic option for the RP patients. Long-term results are still not clear, not known. But there are studies which span over 6 years, and they show good results. So I have been doing this for last 11 months, and I have seen good results in my patients. So there's a case 20-year-old male. He was having RP with all the disruption, central atrophy. You can see. I will just quickly go to a small video for 15 seconds. This is the ERG which shows the RP findings. Treated with 6 sessions, and he had improvement. So this is a 30-second video, just it's a feedback of the patient's father.
नेट रेडनेस है, उसके लिए डॉक्टर साहब इंजेक्शन लगा रहे हैं प्लाज्मा का। तो अभी 6वां इंजेक्शन को लग रहा है, काफ़ी बेहतर है। अब तो मार्केट जाता है, अपना शॉपिंग करता है, पहले बिल्कुल ही डल हो गया होता। अल्लाह का शुक्र है, काफ़ी बेहतर है।
ठीक है जी। आपको लगता है कि इंजेक्शन लगने के बाद अहमद की नज़र में कुछ बेहतरी आ रही है?
बहुत बेहतरी है। मेरे घर पे चार्ट लगा हुआ है, उस पर एक लाइन भी नहीं पढ़ी जाती थी, अब ये 4 लाइनें पढ़ लेते हैं।
गुड, माशाल्लाह। अहमद, आपको लगता है कि इंजेक्शन के बाद आपकी नज़र बेहतर हो रही है? शुक्रिया। आपकी इजाज़त से ये वीडियो हम दिखाना चाहेंगे दूसरे डॉक्टर साहिबान को, आप अगर इजाज़त देते हैं हमें तो।
हाँ, दिखा दे, कोई अर्ज नहीं।
बहुत शुक्रिया आपका। ओके, थैंक यू।
Thank you. Thank you, Doctor. Professor Hamid Mahmood Butt, his talk on PRP, the journey from DRS to DRCR net.
I'll just run through the slides. My idea is to share with the younger generation what I feel. I will not say older generation, because younger are sitting. I was talking to Professor Dawood, but he was saying, sitting on the sidelines in one talk, that there are more than 33 million diabetics in Pakistan. तो टोटल पॉपुलेशन कितनी है पाकिस्तान जी? 25 करोड़, 24-25 करोड़, 22 करोड़ की भी फिगर पुरानी सेंसस विच इज ड्यू. हमने सिर्फ ना थोड़ी सी इंटरैक्टिव सी टॉक करनी है, ऐसे वो स्लाइडें नहीं चलानी. 3-3.5 करोड़ बंदा, और स्टेटिस्टिक्स सीधी सीधी बताती हैं कि 10 साल के बाद 50% को कोई ना कोई रेटिनोपैथी शुरू हो जाती है, और 20 साल में 90%. तो इसका मतलब है 3 करोड़ बंदा पार्क हुआ है, विच नीड्स जस्ट एन एनुअल. और कितना हम्बलिंग है मेरे लिए कि एनुअल डायलेटेड फंडस एग्जामिनेशन करना एज ए एडवोकेसी एंड एज अ प्रिवेंटिव स्ट्रेटजी. कितना ऑप्थेल्मोलॉजिस्ट चाहिए, कितने मैन आवर्स चाहिए. जब पहली दफ़ा मैंने यूएस वीज़ा लगवाया ना, तो वो पेपर वाला था, उसके ऊपर लिखा हुआ था छोटा सा कोने में, एस्टिमेटेड टाइम बर्डन ऑफ फिलिंग द एप्लीकेशन. तो अब आपसे वो ऑनलाइन आपकी एप्लीकेशन भरवाते हैं, अपना टाइम बचाते हैं. दैट्स द वर्ल्ड दैट वी आर टॉकिंग अबाउट नाउ. एंड आर हमारा ये जो फूड पैंडा का, मैं नाम नहीं लेना चाहिए केस ही ना हो जाए मेरे पास, जो ऑनलाइन कोल्ड ड्रिंक्स, ओबेसिटी इज इन एन इंटरनेशनल प्रॉब्लम नाउ. और हमारा प्रेवलेंस रेट डायबिटिक रेटिनोपैथी का 26% पे चला गया. ठीक है. अच्छा, ये तो स्लाइड सबने देखी हुई है कि जी ये इट इज बेसिकली मेटाबॉलिक सिंड्रोम. अब डायबिटिक रेटिनोपैथी नहीं कहा जाता, बहुत सारे डिजीजेस को लंप किया जाता है मेटाबॉलिक सिंड्रोम. और प्रोलिफरेटिव डायबिटिक, और हमारी क्लासिफिकेशन पहले थी प्री प्रोलिफरेटिव, सो वो कहते हैं नहीं जी, नॉन प्रोलिफरेटिव एंड प्रोलिफरेटिव. और इसके बारे में भी बताएं कि CSME आपके ज़हन में इसका क्या, दिस केम क्लासिफिकेशन केम फ्रॉम द ETDRS स्टडी. ठीक है. तो मुझे ये बताएं ETDRS में पेशेंट का विजन क्या होता था जब उन्होंने सेट की स्टडी. तो ऑल ऑफ देम हैड नॉर्मल विजन ऑलमोस्ट. हम तो मैकुलर एडीमा की बात करते हैं ना, तो जो ETDRS ने मैकुलर एडीमा बताया, दैट वाज दिस क्लासिफिकेशन. मैकुलर ड्राई था, फिर भी हम मैकुलर एडीमा को ट्रीट कर रहे. याद रखना है. अगली स्टेज क्या आई, हमने क्या करना शुरू किया, प्रोलिफरेटिव में पैन रेटिनल एब्लेशन एस्टैब्लिश हो गई, और फोकल में CSME में फोकल हो गई, और एक पूरी जनरेशन रेटिना की इस पे चलती रही. और एक बीच में एक वो था वन एरिया वेयर वी हैड डिफ्यूज डायबिटिक मैकुलर एडीमा, उसमें हमने शुरू कर दी, विच बहुत ही रिजर्व के साथ. उसके रिजल्ट्स हमारे पास इतने अच्छे नहीं थे. दीज टू वर स्टैंडर्ड ट्रीटमेंट्स. व्हाट आई एम ट्राइंग टू से इज, इन द प्रॉपर पेशेंट with where you were doing PRP, and in the proper patient where you're doing focal, this was the standard of care. Next came this era, center involving diabetic macular edema, और हमारे पास, and then we got the OCT. ठीक है. And now we had this wonder drug called anti-VEGF. अब मैं, there are just a couple of slides which are just based on evidence-based practice. ये नहीं कि मैं क्या कह रहा हूं या आप क्या कह रहे हैं. This is a new world of patient care, evidence-based. So the protocol S compared that in proliferative diabetic retinopathy or in center involving diabetic macular edema, we give anti-VEGFs as the gold standard. तो उन्होंने कंपेयर किया PRP for proliferative diabetic retinopathy and the ranibizumab as the prodrug as an anti-VEGF. So how many of you have actually gone through the protocol S? Has anybody read the recommendations of protocol S? जिसने पढ़ी है तो आपसे नहीं पूछूंगा, मैं नई जनरेशन से पूछूंगा. आपने प्रोटोकॉल एस पढ़ा है? कोई रेजिडेंट्स बैठे हुए हैं यहाँ पे? कोई यंग ऑप्थेल्मोलॉजिस्ट जो कि आ रहे हैं? अच्छा, अब हमने देखना क्या है क्या हम पढ़ते हैं एविडेंस बेस्ड प्रैक्टिस? एविडेंस बेस्ड प्रैक्टिस का मतलब है आप लिटरेचर के ट्रायल को मरीज की बेहतरी के लिए इस्तेमाल करें, बस, इससे ज्यादा कुछ भी नहीं है कि दुनिया क्या कह रही है एविडेंस बेस्ड प्रैक्टिस की। सो व्हाट डिड दे रिकमेंड? ये तो उन्होंने कंपेयर किया ना दोनों को, और ये पहले इसके 2 साल के रिजल्ट्स थे, अब 5 साल के भी पब्लिश हैं, 2018 के पब्लिश हैं। हम बहुत पीछे जा रहे हैं। लॉस टू फॉलो अप 60% प्लस इन दिस स्टडी। उसकी इंटरप्रिटेशन क्या है? उसकी इंटरप्रिटेशन ये है कि पीपल इन यूनाइटेड स्टेट्स ऑफ अमेरिका कुड नॉट अफोर्ड to get the anti-VEGF for 5 years. Are you getting this? What I'm trying to say? 60% लोग, उर्दू में कर देता हूँ क्योंकि मेडिकल एजुकेशन में आई थिंक लैंग्वेज इज वेरी इंपॉर्टेंट। 60% लोग प्रोलिफरेटिव डिजीज के रेनिबीजुमैब मुकम्मल 5 साल तक नहीं लगवा सके। व्हाट टू टॉक ऑफ अस? एक दूसरा, ये वी हैव टू रिमेंबर जो कैपिलरी ड्रॉप आउट का एरिया है ना और इस्कीमिक एरिया है, वो इस्कीमिक ही रहना है डायबिटिक रेटिनोपैथी का। नो ट्रीटमेंट इन द वर्ल्ड इंक्लूडिंग द एंटी वेजेफ्स कैन इंप्रूव और रिवर्स द कैपिलरी ड्रॉप आउट एरिया। इट ओनली प्रिवेंट्स और ब्लॉक्स द एंटी वेजेफ विच इज ऑलरेडी फॉर्मिंग। तो ऐसे ही है जैसे आप एक गाड़ी आपकी, जैसे आपकी क्लच फ्री गाड़ी होती है ना, तो आप उसकी ब्रेक पे पैर रख देते हैं तो रुक जाती है, जैसे ही पैर उठाते हैं फिर चल पड़ती है। लेट मी पुट दैट एनालॉजी। आपने एंटी वेजेफ दिया, वो 1 से 2 महीने तक जितना भी उसकी ड्यूरेशन है डिपेंडिंग ऑन द मॉलिक्यूल, वो एंटी वेजेफ को ब्लॉक करेगा। द मोमेंट एंटी वेजेफ का इफेक्ट खत्म हुआ, एक्सीलेटर उठाया, गाड़ी फिर चल पड़ी। सो यू नीड कॉन्स्टेंट एंटी वेजेफ इंजेक्शंस। और इसको अभी मैं थोड़ा सा शेयर करूंगा और फिर ओपन करूंगा डिस्कशन के लिए। लुक एट दिस ग्राफ। मैंने जब ये ग्राफ देखा तो मैंने कहा यार हमारी लिटरेसी अगर एविडेंस बेस्ड प्रैक्टिस, you take this photograph and use it in your everyday practice as evidence-based practice. You know, initially the yellow is PRP, orange. Now top वाला जो है that is the ranibizumab group. 5 साल के बाद दोनों results, दोनों lines जुड़ गई हैं। एक चीज जरूर याद रखनी है, आपने ये नहीं, इससे मैं ये नहीं कह रहा कि आप एंटी वेजेफ्स को छोड़ दें और सिर्फ पीआरपी दोबारा करनी शुरू कर दें। रिमेंबर, ईच ट्रीटमेंट हैज इट्स ओन प्रॉपर प्लेस। इफ देयर इज अ मैकुलर एडीमा, व्हेन यू, सम पीपल डू गिव वन एंटी वेजेफ इन विद अ कोएग्जिस्टिंग, प्रोलिफरेटिव डायबिटिक रेटिनोपैथी है, मैकुला वेट है, एक एंटी वेजेफ लगाएं, हफ्ता 2 हफ्ते वेट करें, पीआरपी शुरू कर दें। और दरमियान में भी अगर आपको लगता है कि पीआरपी इंड्यूस्ड या अदरवाइज, बिकॉज द पीआरपी टेक्स अबाउट 3 months to settle down, so that is when you can top it up with anti-VEGF in between also. Are you getting this? So that is the recommendation which I would like to share, और ये भी इसके conclusions में है। और there was, इसकी लास्ट फिगर पे आ जाएं आप लोग जिन्होंने डिसर्टेशन में है, और एविडेंस बेस्ड प्रैक्टिस स्टेटिस्टिकली सिग्निफिकेंट पी वैल्यू is or between the two groups in terms of visual acuity. लास्ट लाइन पे आ जाएं। इस डायग्राम की सिर्फ एक स्टेटिस्टिकल सिग्निफिकेंस 0.11, 0.24, 0.6, 0.6 नॉट सिग्निफिकेंट। 0.05 पे सिग्निफिकेंट लेवल होता है, ये एक अलग डिस्कशन है। लेकिन कोई भी रिजल्ट अगर 0.05 पे नहीं आ रहा, it is not statistically significant. That is the reason the two lines merge. In between, those who had diabetic macular edema in both groups were qualified to receive ranibizumab. Are you getting this? This is also very important. You don't deny treatment. The trial becomes unethical if you deny treatment. So those who had macular edema were given anti-VEGF in both groups. Late and their recommendations. Kyunki in the interest of time, I dug out another article, 2022 Royal College of Ophthalmology का official journal है, जैसे हमारा PGO है। Take a slide of this. So I would like you to have 2 slides with you. One, protocols. And second, this study in 2022, which says the use of wide field OCTA revealed no sign of reperfusion of retinal vessels post anti-VEGF treatment. Full stop. And this is the diagram from this 2022 study. The capillary dropout areas as related to the OCT angio. They used this as evidence to prove that reperfusion nahi hoti anti-VEGF ke baad. And this is the last slide. I would like to read it. One, although loss to follow-up was relatively high in this cohort, visual acuity in most study eyes that completed follow-up was very good over 5 years. Minus the 60%. Severe vision loss or serious complication of proliferative diabetic retinopathy like neovascular glaucoma, iris envy, or macular traction retinal detachments were uncommon with PRP or ranibizumab. On an average, they required 9 injections every year, and it reduced over a period of time. इसका मतलब है हर महीने 1.5 महीने बाद एक टीका लग रहा था. And the cost, इसीलिए 60% could not be supported. There were no meaningful treatment group differences in patient-centered outcomes, which means visual acuity, stabilization. Or last one, individual patient factors such as anticipated potential for maintaining scheduled visits, number of visits, cost, and systemic health should be considered when choosing a treatment for proliferative diabetic retinopathy. One, these findings support either ranibizumab or PRP as viable treatments for proliferative diabetic retinopathy. So, keep your lasers with you. Keep doing pan-retinal photocoagulation, please. And use anti-VEGFs very judiciously. और मेडिकल रेटिना एसोसिएशन के फोरम से अगर मैं एक मैसेज दूं तो वो ये है, with the current crisis और नहीं वैस्टिन, एंड यू नो हमने कितना स्ट्रेच किया. वो कहते हैं ना रबड़ को स्ट्रेच करें तो आपके मुंह पे वापस आगे लगता है. ऐसे ही होता है ना, किसी चीज को आप खींचते जाएं. इट इज a reality now. So now you are forced. नेचर के साथ आप एक हद तक प्ले करते हैं ना, फिर नेचर नहीं छोड़ती. नेचर अपना साइकिल सर्ट कर देती है. तो वी हैव टू बी वेरी porous. New recommendations naturally are going to be come up with more rigor कि कहाँ पे anti-VEGF लगाना है, कहाँ पे नहीं लगाना है, Avastin particularly. और क्योंकि दोनों treatments बाकी जितने भी branded drugs हैं, they are very costly, so you can actually use them very very carefully in both focal photocoagulation and pan-retinal ablation. और ये जो जरूर अपने मरीजों को कहें कि जी अपनी हीमोग्लोबिन A1C 6 और 7 के दरमियान रखें, बिकॉज वट एवर यू डू, ये सिस्टेमिक हेल्थ की बात है, कॉस्ट की बात है, नंबर ऑफ विजिट्स की बात है. तो मैं तो अब हर मरीज को अब कुछ सालों से कहना शुरू हुआ हूं कि अगर, दिस इज वेयर आई क्लोज सर, कि अगर आप अपनी ब्लड शुगर 100 फास्टिंग और 200 से नीचे रैंडम रखेंगे तो 3 महीने की एवरेज आपकी 6 और 7 के दरमियान आएगी हीमोग्लोबिन A1C की. दिस इज ए कम्युनिकेशन. फेको करते हो ना आप, कहते हो जी रेक्सिस कितना अच्छा किया. दिस इज द कम्युनिकेशन स्किल्स सेंटेंस जो आपने तोते की तरह हर मरीज को, डायबिटिक वाले को रिपीट करना है. दिस इज द स्किल दैट यू एज अ कम्युनिकेटर, मीनिंगफुल, वन सेंटेंस. एंड UKPDS and the DRCR, DCCT हुई हुई है, ये भी 20-20 साल पुरानी है. वो कहती हैं कि अगर आप ये ब्लड प्रेशर और ब्लड शुगर दोनों मल्टीप्लाई करते हैं तो 140/90 ब्लड प्रेशर, हीमोग्लोबिन A1C 6 और 7 के दरमियान. और उनसे मैं ये भी कहता हूँ जी आपके RBCs की उम्र 3 महीने है, 120 दिन. तो हर 3 महीने बाद हीमोग्लोबिन A1C आपने साल में 4 रीडिंग्स मुझे ला के देनी है. So these are the references. You can please take a picture, those who want to study, especially the upcoming generation. बहुत थोड़े से पहले 2 रेफरेंसेस ही. और दूसरी बात यह है कि हम इतने आसानी के दौर में अब रह रहे हैं, आपका अपने स्मार्टफोन पे अभी डाउनलोड कर लेते हैं। हमें तो रेफरेंस नहीं मिलता था, हमें तो डिसर्टेशन के लिए नहीं मिलता था, हमें तो किताब नहीं मिलती थी कि कहाँ से पढ़ें हम। तो यू आर वेरी फॉर्चुनेट। लेकिन क्योंकि इतना इंफॉर्मेशन ओवरलोड है कि आपको पता ही नहीं लगता हमने क्या करना है, सारा दिन बस टिकटॉक 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 हो रहा था। तो टिकटॉक में से थोड़ा सा टाइम निकाल के ये वाली भी देख लें। थैंक यू वेरी मच।
Thank you, sir. Dr. Sidra Riaz, her presentation is on OCT and its role in visual prediction in diabetic macular edema. Now, my request to the speakers is please stick to your time. The time is 8 minutes. I'm asking the rest of the speakers, sir. It was a very nice lecture, and we have learned a lot from it. Thank you, sir. So, Dr. Sidra Riaz.
Assalamu alaikum. My topic is OCT role in diabetic macular edema. As Hamid Saab has very rightly said and informed us about the burden of diabetes in our population. So diabetic macular edema is biggest number one cause of decreased vision in diabetic patients. OCT is one of the excellent tools, although little expensive. Food is non-invasive, reproducible, using infrared light, and even it can do it in non-dilated pupil to give us information in a very little time. Prerequisite is, of course, the clear media and the good fixation of eye. So the early patients who have good fixation and media opacity. This is how OCT image is produced, that it is the hyper-reflectivity and hypo-reflectivity of different layers of the retina, which can give us some information about the current status of the retina. Here, the two layers are very important. Number one, this external limiting membrane and ellipsoid zone, and inner and outer retina at the level of macula, which can give us information according to which we can predict the final vision outcome in diabetic patients. Type of OCT scan are 3 different scans, but we are using line scan and grid map in patients of diabetes in order to get more information about macular area. Whenever you see the OCT, we divide it into 5 slabs, starting from vitreomacular phase to the outer retina, and these 5 layers are important for prediction of final vision outcome in after or pre-treatment of diabetes. How OCT helps? Number one, it documents the initial thickness of macular retinal thickness, which is at the time of presentation. Number two, it tells us about that either medical treatment is enough or we need to go forward for surgical treatment or refer the patient. And number three, what would be the final vision of patient? For example, in this slab, if you see the inner slab, here you can see that vitreomacular traction is very evident, and this case is unlikely to be resolved only with medical treatment. So this patient needs VR surgery for improvement. Here, this vitreomacular traction is more evident. So unless you remove this traction along with diabetes control, patient is not going to be fine. Here you see that there is a gross cystoid edema involving outer as well as the inner retinal layers of patient. So this patient is more likely to be get better with the help of medical treatment. That, of course, start with systemic control of diabetes. This is the clinical significant macular edema definition. You all know about this. So you need to remember this figure, 275 micron. This is the upper limit, including diabetic patients, that if any macular thickness, it is receding beyond 275 micron. In some books, 255 is also present, but most book they have mentioned this value 275 micron to be as upper limit, that macular thickness should not be more than this. And how OCT helps? Number one, diagnosis. You have already diagnosed the clinically significant macular edema on your clinical evaluation, but in order to document the extent of this and macular thickness, you can use OCT. Number two, it helps to gauge the response of your treatment. You are giving anti-VEGF and you are doing the serial OCTs in order to know that either subretinal fluid is going or not. Then it helps us to monitor the disease. Of course, it will be in hand by hand with your visual acuity monitoring. And in order, what treatment strategy is required? If there is vitreomacular traction or tractional retinal detachment, then surgery will be the answer. And if cystoid spaces are present, then medical treatment will be the first option. Here you see the pathogenesis, how as diabetes is a vascular disease, so there is increased level of leakage starting from inner and outer retinal barriers, which will cause the more exudation, subretinal fluid, and increased thickness at the level of macula. These are 4 different types of macular edema which you can pick up at OCT, and usually these are with and without hyperreflective spot. So what you need to know while you see the OCT of a diabetic patient, number one, absence and presence of subretinal fluid. Number two, hyperreflective spots. These are seen only in diabetes and age-related macular degeneration. Number three, the presence or absence of any retinal detachment at the level of RPE. Predicting factors would be disruption of ASOS layer and ellipsoid layer. Number two, intact external limiting membrane. The patient who present with macular edema and ellipsoid zone or external limiting membrane is intact, then they have more chances of better visual prognosis as compared to the patient which have disruption of this ellipsoid zone or external limiting membrane. The presence or absence of hyperreflective spots, it tells us that there is a degenerative process, and the hyperreflective spots, they tend to diminish with the help of anti-VEGFs. Microaneurysms, they are hyperreflective spot at the level of outer retina, and hyperreflectivity around microaneurysm, it shows leakage. Here you see that starting from lower to upper end, that visual acuity will be very less when the macular edema is going beyond 300 micron, and lesser the subretinal fluid, better will be the visual outcome. Here are few cases. A female patient present 72 years old. She had diabetes for 10 years, and you can see here that her right eye is affected with macular edema. Now in this OCT scan, you can easily realize that hyperreflective spots are present at the level of outer retina. The normal foveal depression is not seen in this patient, and there is also disruption of ellipsoid zone in this patient. Left eye was relatively normal with only few hyperreflective spots at the outer retina. So this patient needs medical treatment as well as communication, or as well as we need to tell this patient that visual prognosis will be not as good because ellipsoid zone and external limiting membrane both are disrupted. Here is another case in which you can see bilateral clinically significant macular edema and partial posterior vitreous detachment. This case received bilateral 3 anti-VEGF injection, and postoperatively she was better. Now you can see and compare the pre-anti-VEGF OCT and post-anti-VEGF OCT. Here you can see although the disruption of external ellipsoid layer is also present, but her subretinal fluid level has resolved. Here is another case. This case is only to show you that this patient has a history of retinal TRD surgery for one eye, and vision was very poor as well as the media was poor. So OCT was not as reproducible and reproductive as usually seen. It seems that this OCT scans show that the media must be clear in order to document this OCT scan better. This is another case in which he is a young patient, below 50 years of age, and you can see the tractional element in both eyes, left more than right. He is also suffering from hypertension and hyperlipidemia. This patient shows the homogeneous increase in thickness on OCT, retinal thickness, and on left eye, not only the layers are disrupted, but also there is a tractional element. So this OCT tells us about, number one, the prediction of visual outcome in left eye, where the tractional element is also present and lot of hyperreflective spot on the external level of retina. So visual prognosis would not be good. Here is an last patient, female patient, diabetic, history of lasers. And here you see on the upper level, she is responding to anti-VEGF, but vision was not good at the end because there is a thick epiretinal membrane which you can see at the level of vitreomacular interface in left eye. So this patient needs anti-VEGF as well as VR surgery. This is the last patient.
Dr. Sidra, can you please
Sir, last case. This is the patient who have chronic hyperreflective spot at the level of external retina as well as the disruption of all ellipsoid layers. After receiving Eylea injection, you can see the results were very nice. All subretinal fluid was resolved and his subjective visual acuity was also better. And he got 612 vision in one eye from 660. Here is the final OCT reports of this patient after getting 3 Eylea injections. Thank you. Thank you very much.
Thank you, Dr. Sidra. The next speaker is Dr. Amir Arain. His talk is on managing combat ocular trauma as a vitreoretinal surgeon, a 2-year experience. Dr. Amir Arain. You see, many speakers are already waiting, so please stick to your time. The time allocated is 8 minutes. Please.
Bismillahirrahmanirrahim. I am Dr. Amir, and presently I am in AFIU as a vitreoretinal surgeon, but I have been posted in CMH Peshawar, and that was an area of war on terror, and I have managed multiple patients of combat ocular trauma. So few of the cases and a video as well. Open globe injuries, they often result in severe visual loss, and intraocular foreign bodies, they account for 18 to 41% of all open globe injuries. And most posterior segment IOFBs, they reside in posterior segment. The visual prognosis depends on IOFB size, zone of injury, and the accessible treatment. These IOFBs, they can be removed from the sclera, from the cornea, or by a tunnel. I'm showing you a video of a case of a bomb blast injury and its management, secondary management by the VR surgeon. This study was conducted at VR department CMH Peshawar from January 2022 to October 23, and all the patients with history of VR trauma, they were included, and initial workup was done, and later the final visual outcome was measured by the Snell's visual acuity and the flatness of retina. The location and size of IOFBs, it was identified by the CT scan, And consent was taken by keeping the ocular trauma score as a reference. And it's very important once you are dealing with cases of ocular trauma with IFBs, you must first explain the prognosis of the patient. That's very important. Then primary repair was done, followed by pars plana vitrectomy. This is the ocular trauma which we were using. Most of the time with this ocular trauma score, the patients of war-wounded injury, they fall in ocular trauma score 1, and I tell them that the chances of vision is only 27%. Now this is a case presentation of a young soldier with splinter injury in his right eye, and visual was PL positive, primary repair was done, and finally after removal of foreign body, a 3-piece IOL was placed, and final visual acuity was 6/12. Well, this is the case. Primary repair was done. Lens was aspirated. You can see a posterior capsular rupture also there. So PACRS are placed, 23 gauge. Core vitrectomy was started first behind the capsule. PVD was induced. Core vitrectomy was completed. Now this is the foreign body there. I'll first relieve all the tractions of this foreign body with the vitreous. The foreign body has been relieved. Now the peripheral vitreous is being trimmed. Now with the forceps, a 23 gauge forceps, this foreign body is brought into the AC. Through the hole in the posterior capsule, it's brought into the AC, and with another forceps, it is removed through the limbal incision. It's a difficult part, but finally, this is a metallic intraocular foreign body. And I am going to search with indentation 360° in case some break is created. 360° search was done and no break was seen. And now a 3-piece MA60 AC IOL is placed in the sulcus. You use B cartridge to put this IOL, not with the standard C cartridge. The gel is removed from the anterior chamber and the wound is secured with a 10-0 nylon. And now the gel which has gone posteriorly is taken with the help of the black flesh needle, and now this capsular opacification is removed with the help of the cutter to make the media clear. Finally, the central stitch will be removed. The center of the capsule is cleared. The stitch is removed. The trocars are removed. since there was no break, so there was no need for any tamponade. And this is the final outcome. Patient 612 vision post-operatively. So total of 37 patients, they were managed, and all of them were male. And the nature of foreign body was metallic in 100% of cases. 98% of the patient, they were having visual acuity less than 6/60, only 2 having better vision. And you can see the penetrating sites from cornea, corneosclera, sclera, patients with iris injuries, lens injuries, vitreous hemorrhage, RD, endophthalmitis. And silicone oil was used in those patients who had retinal injury or there was a break. And as a standard, silicone oil was removed after 3 months. This is the post-op results. We were able to salvage all the patients with navigational vision, with 35 patients less than 636 and greater than 618 in 17% of patients. So intraocular foreign body is a serious problem in young age population, especially soldiers and people facing war on terror. We use 23 gauge in all cases and IFB extracted from the corneosclera or sclera. Good pre-op visual acuity and good pupillary response was associated with good vision. Now, this study, it is comparable with the international data. And now I'll share few surgical tips. Number one is never do an MRI. Always measure the size of intraocular body on foreign body on CT scan. And always go for a 3-dimension scan, because radiologists, they often give you 2D scan and you can be stuck somewhere inside if you don't know the exact size. Then these heavy foreign bodies, especially of these bomb blasts, they cannot be, you cannot brought them up by PFCL. And this is a very important thing, that always measure the tip of your instrument with a caliper before you are going in, because the foreign bodies, they are large, and most of the time the forceps we are using, their tip opens only 2 mm. If the foreign body is more than 2 mm, it require another separate instrument. And if you don't do these calculations and you think that you are going to manage it intraoperatively, these IOFB don't forgive you. Then while calculating the size of IOFB, you should add the 2 sides of IOFB. Means if it is 4/3 means 7 mm. If it is 2/2 means 4 mm incision would be required. And then add the size of the forceps, which is required to be placed inside, and then add at least 1 mm, 0.5 mm on either side to get the IOFB out. And with this calculation, if the size is like greater than 5 mm, and go for the limbal incision. With the tunnel, better, or if it is small, you can go for simple corneal incision. And then in blast injuries, intraocular foreign bodies are multiple. And you may have to do a clear lens extraction to remove the intraocular foreign bodies. And you should keep a 3-piece IOL beforehand before you are doing. Then do a laser retinopexy at the retinal wound and place silicone oil in these cases. And always keep Denseron and 2 to 3 PFCL. In one case, I had to use 3 PFCL while I was trying to extract the foreign bodies, because it was very heavy and it was difficult for me to manage it. And for the timing of vitrectomy, I would say that earlier the better. So if the media is clear, and if you do the vitrectomy at the time of primary repair, you'll get the best results. As late as you go, you'll encounter more PVR. But don't go if the visibility is poor. So in conclusion, I'd say that the prognosis of patient was good, with good presenting visual acuity, and timely repair, primary repair and VR intervention is the key to success in such cases. Thank you very much.
Thank you, sir. Dr. Nazish Khan. Her presentation is on 23 gauge vitrectomy with internal gas tamponade for the management of red heterogeneous retinal detachment.
Starting with the name of Almighty Allah, the most merciful, the most beneficent. I am Dr. Nazish Khan, consultant ophthalmologist from Al Shifa Eye Trust, Sakkar. This was my article. It was published in PGO volume 39, 23 gauge vitrectomy with internal gas tamponade for the management of RRD. Why gas as an internal tamponade? Basically, we want to readdress the issue of using oil as internal tamponade in every posterior segment surgery without thinking twice that oil has specific complications. Use of oil needs one more surgery to remove it. So we have restricted the use of oil in cases of end-off and GRT cases. Gas as a tamponade have both increased surface tension and buoyancy than silicone oil. 23 gauge vitrectomy is basically 0.7 mm. It is sutureless, rigid instrumentation, improved light transmission, allowing greater rotation of the eyeball, and the ability to perform a more complete vitrectomy. Greater flow rates can be achieved with 23 gauge system so that certain parts of the vitrectomy, such as removing posterior haloid, can be done effectively and efficiently. Our purpose was to evaluate the anatomical and functional outcomes and complications. All the patients were of RRD with total 55 patients. Mean age was 49 to 17 years. 23 gauge PPV with gas C3 F8 tamponade was used, 14%. We have evaluated anatomical success, change in the best corrected visual acuity, and incidence of the complications. Follow-ups were done like this. Patients were evaluated daily up to the 4th post-op day to see increased IOP spikes. Maintenance of head-down posture was advised. Paracentesis was done if IOP was very high, like 50 mmHg, or if the eye was painful. We have done this in the OPT setup in supine position passively after the first 4 days. Weekly follow-up were done until the gas was absorbed. This is the stats, like pre-op visual acuity was improved after the gas using the as internal tamponade. Mostly the all of the four quadrants were involved in our cases pre-op. Most of the cases have macula off, and most of the cases were pseudophakic. We also place an external band in cerclage in eyes greater than 25 mm axial length or eyes with inferior RDs. So we have used, in 28 cases, we have used the band. Then the cause was myopes. Then it was trauma, pseudophakic lattice. Then need of redo was in 4 of the cases. Anatomical success, yes, we achieved in 51 of the cases there was good vision after the post-op. Steps of vitrectomy, these are the basic steps: core vitrectomy, then PVD, then meticulous peripheral vitreous removal was done. Perfluorodecaline was applied to immobilize a centrally detached retina and to facilitate the evacuation of SRF through the peripheral breaks. If ERM was present in the macula where its presence was suspected, brilliant blue dye was used, and ERM and ILM peeling was done under heavy liquid. Air fluid exchange was done. Then heavy liquid is when air fluid exchange was done using vitrectomy probe to drain fluid from the subretinal space through the break. Here, heavy liquid is up to the tear, and above the tear is air. So now we have a situation when the tear is sandwiched between the heavy liquid and the air after all the sub-SRF was removed. Complete fluid-air exchange was performed using Charles fluid cannula to ensure complete air-fluid exchange over the disc, macula, and periphery. Retinopexy of 360-degree periphery was performed under air using endolaser. Vitreous cavity was flushed with 100 cc of C3F8 gas mixture between 4 to 14% according to the need from the infusion port, and flushed through the open port on the other side. Intraorbital triamcinolone was given in the end. We also ensured at the end that there is no wound leak. If epithelium was removed, we have placed BCL. Conclusion is that in our study, 92.7% of the patients were found with anatomical success. The surgical treatment of RRD using 23 gauge PPV with expansile gas internal tamponade have good anatomical results and improvement in the best corrected visual acuity. Thank you.
Thank you, Dr. Nazish. Dr. Nurul Ann, her talk is on chicken skin with cracked eyes.
So, Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Nurulain. I am a postgraduate resident at Mughal Eye Hospital, and today I will be talking about chicken skin with cracked eyes. I declare no conflict of interest for my presentation. So, there was this 54-year-old male resident of Attak district, KPK, Pakistan, painter by profession, married, who presented to us in our OPD with a complaint of decreased vision and altered shape of objects in both eyes for 10 days. The decrease in vision was sudden in onset, pain with metamorphopsia and micropsia. However, there was no aggravating and relieving factors. On asking about the systemic history, the patient was non-diabetic, non-hypertensive. There was no history of ischemic heart disease, no history of ocular surgery, laser, injection, or trauma. The family history was also unremarkable. However, on asking about the past medical history, he told us that he had gone through to a general physician for the appearance of these bumpy lesions on the sides of the neck. The general practitioner has advised him for the topical mild steroids, which he had been using on and off since then. Surgical history was also unremarkable. We did the ocular examination of the patient. On that, the visual acuity in the right eye was 636, while that in the left eye was also 636. The best corrected visual acuity in both eyes were 624. All the anterior segment findings were within the normal limits. However, on examination of the posterior segment, there was altered foveal reflex and dull appearing macula in both eyes. The irregular crack-like appearance radiating from the peripapillary area suggested the presence of angioid streaks in right as well as in the left eye. Considering the presence of angioid streaks and its systemic association, we did a very vigilant systemic examination of the patient, and there we found the culprit. The presence of these plucked chicken appearance on the sides of the neck. This is the picture of the patient from the front view. As you can see, the presence of these plucked chicken appearance. The view from the right and the left side of the neck. We did the investigation that involved the OCT macula and FFA, the fundus photograph of the patient of right eye that shows the presence of angioid streaks as well as the presence of choroidal neovascularization. The fundus photograph of the left eye. When we did the fundus fluorescein angiogram, we showed the presence of hyperfluorescent streaks in both eyes radiating from the peripapillary area that was suggestive of the presence of angioid streaks, along with the presence of hyperfluorescent areas of staining and leakage that showed the presence of CNV in the right eye. This is the fundus fluorescein angiogram of the right eye. As you can see in this picture, the presence of choroidal neovascularization associated with angioid streaks. This is a magnified view of fundus fluorescein angiogram of the right eye. FFA of the left eye. OCT showed the presence of choroidal neovascularization. So the presence of angioid streaks along with the choroidal neovascularization and the skin lesions at the sides of the neck that give the plucked chicken appearance of the patient brought us to a diagnosis of pseudoxanthoma elasticum. Pseudoxanthoma elasticum is considered to be a rare condition in which there is a prevalence of 1 in 25,000 patients. It's a rare autosomal recessive disorder that occurs because of the mutation in ABCC6 gene on chromosome number 16. As a result of that, there is elastoresis and calcification and fragmentation of not only the elastic fibers of the skin, but also the eyes and cardiovascular system. This is the picture that will help you understand, as it's a multidisciplinary approach. So considering this picture, it will help you understand that the angioid streak, the prevalence of angioid streaks is 6.5 per 100,000 person. Most of the patients remain subclinical for the presence of pseudoxanthoma elasticum. However, if you want to see that the presence of angioid streaks occurs before the diagnosis of pseudoxanthoma elasticum, angioid streaks was diagnosed before pseudoxanthoma elasticum in 63.9% of the patients, as in our case as well. Pseudoxanthoma elasticum diagnosis before angioid in 25.3% of the patients, and simultaneous diagnosis was made in 10 to 7% of the patients. Management involves the multidisciplinary approach. So as in our case, we basically brought on board cardiologists as well as general physician and the ophthalmologist. Complication associated with the presence of pseudoxanthoma elasticum and involves the choroidal neovascularization. And the second thing that I want to elaborate is the development of choroidal neovascularization in the presence of angioid streaks itself is very challenging. However, we have the approaches like laser photocoagulation, photodynamic therapy, transpupillary thermotherapy, macular translocation that has limited results till yet, and anti-vascular anti-VEGF injection. Owing to the absence of other modalities like photodynamic therapy or macular translocation surgery, we did the intravitreal anti-VEGF injection in our patient. So what I want to conclude in my presentation is the fact that the diagnosis of pseudoxanthoma elasticum was basically missed by the GP and referral to the ophthalmologist was not made on time. Other than that, the management of CNV in pseudoxanthoma elasticum itself is very challenging. So these patients need regular ocular examination to detect the presence of angioid streaks before they reach the fovea, resulting in irreversible loss of vision. The take-home message is many systemic diseases have ocular association as well, just like this. If not referred to the ophthalmologist in time, it can lead to disastrous outcomes and sight loss. In contrary to that, all the patients coming to the ophthalmologist should also be examined for the presence of any systemic illness as well. Thank you.
Thank you, Dr. Nurul N. Now, she was the last speaker. Any question and answers from the audience? No. So thank you very much. This was the end of the Medical Retina and the Surgical Retina Symposium. Thank you very much for your participation and patience.